My name is Monica Polcz. I'm a resident at Vanderbilt University Medical Center, and we are very thankful for the opportunity to present our work today. I have no disclosures. The optimal method of abdominal wall reconstruction in contaminated fields remains unclear. There's been a historical preference towards the use of biologic mesh reinforcement due to fears of contamination if synthetic mesh were to be used. However, the use of lighter weight macroporous synthetic mesh has become more common. Therefore, the purpose of the study was to evaluate outcomes of hernia repair in this setting using lighter weight synthetic mesh in contaminated fields. We use the ACHQC database for this study, which is a large, prospectively and surgeon-maintained hernia-specific national registry. At the time of data acquisition, there were 151 participating institutions. We looked specifically at adults who underwent ventral incisional hernia repair with light or medium weight synthetic mesh, and compared outcomes between those that were performed in clean, containing CDC class 1 versus contaminated, including CDC class 2 and 3 settings. Outcomes of interest included 30-day surgical site infection, surgical site occurrence excluding infection, and surgical site occurrence requiring procedural intervention, as well as 1-year rates of clinical recurrence, mesh infection, or mesh removal. When comparing contaminated to clean cases in our unadjusted analyses, there were higher rates for all outcomes in contaminated cases other than 1-year clinical recurrence. Of note, follow-up data was only available for around 20% of patients at 1 year, and this did significantly limit our 1-year analysis. On adjusted analysis, there was 2.8 times odds of surgical site infection at 30 days in contaminated compared to clean cases, about 2.5 times the odds of surgical site occurrence requiring procedural intervention, and around 1.3 times odds of surgical site occurrence excluding infection at 30 days. Again, in our adjusted analysis, 1-year recurrence rates were not statistically different. We then further subdivided contaminated cases into CDC class 2 or clean contaminated and compared to CDC class 3 or contaminated cases. On our unadjusted analysis, we noted higher rates of 30-day surgical site infection as well as surgical site occurrence requiring procedural intervention in contaminated compared to clean contaminated cases, as well as higher rates of 1-year clinical recurrence. On our adjusted analysis, there were higher odds noted of 30-day surgical site infection by a factor of around 1.8. In conclusion, ventral incisional hernia repair using lighter weight mesh in contaminated fields have higher association with 30-day wound morbidity, as well as 1-year mesh infection and removal rates. And as the level of contamination increased, so did the rate of 30-day surgical site infection. Therefore, further studies are warranted to evaluate best practices in contaminated wounds, and a number of studies that exist currently in the literature sort of group clean contaminated and contaminated cases together, but it may be best to consider these separately given the increased odds of surgical site infection. And I'm happy to take any questions.